Good morning. It's a real pleasure for me to be here, and I welcome you. I am going to speak from a Category C level of evidence, which means that there aren't a lot of clinical randomized prospective trials of management of patients with this condition that we're all interested in of congenital heart disease. And so I think that I want to just share with you what my typical morning is like in my Special Moms, Special Babies clinic. So my first patient maybe is a 31-year-old prima gravida. She has a history of aortic stenosis with a failed Ross. She has a bioprosthetic valve. She has aortic root-sparing graft, but she runs marathons, bikes over 100 miles a week, and she's at 39 weeks preparing for delivery. So that's my patient one. And then patient two is a 32-year-old gravida 3. She's got a VSD, repaired coarct, a bicuspid aortic valve. Oh, by the way, she has a St. Jude's aortic valve as well now, and she's got PROM, and she's at 29 weeks, and she's on Coumadin. Or my 40-year-old who's got monodi twins and repaired tetralogy of Fallot, and she has no meds, she has a preterm labor, and now she's at 30 weeks, and she's laboring. Or finally, this is a 20-year-old who's at 16 weeks with unexplained dilated cardiomyopathy. She has an ejection fraction of 20%. She's in an abusive relationship. She was just recently jailed. She's on metoprolol, Lasix, and hydralazine. These are not made-up patients. This is what my morning looks like. And so managing these patients is both a challenge but also a joy, because all of them have one thought. If you can have a healthy baby, it means I'm a normal woman. No matter what I have in terms of my heart problem, I can have a healthy baby, therefore I'm okay, I'm normal. So my first point is, where do we start with someone who comes in for the first case? And I think that the most important piece for all of us is to think, can we get to them before they're pregnant? And I have to really thank my colleagues at Children's Hospital, because very often when they see a patient who is interested in pregnancy, before she actually becomes pregnant, they send her to me for preconceptual counseling. And this is invaluable because it gives us a plan on what to do, how to manage, what to talk about. All of these things are so valuable, and I really, really appreciate that. What do I talk about? Well, obviously, Dr. Ito has already briefed you on the nature of congenital heart disease, but I want to know how and when it was repaired, when was the last surgery, what's her functioning right now? Does she exercise? Does she ride bike 100 miles a week? Cool. What's her daily living functioning? And are there any recent changes in her function? These are all really critical, and often the patient, I find, is very much her own advocate. She has made the decision to really be very aggressive and take charge of her health, or the opposite pole, she sort of has no idea what was done to her when she was a kid, and now she's just sort of like trying to make her way through her life. What are her medications? What are her medications been recommended? Has she been taking them? Yeah, right. What's her diet? Nowadays, I feel like people are all very difficult to feed. When I have Thanksgiving at my house, I have a lady who's celiac or vegetarian. I live on a farm. I raise turkeys. They got to eat what I have. So the point is, not everybody does that. So you have to recognize that there's a variety of things that people are going to eat, which may impact some of their, both metabolism of their medications, but also how their general health is. What other medical concerns? Does she have hypertension? Does she have diabetes? We don't mention it a lot, but a substantial number of patients with congenital heart disease also develop diabetes, not just gestational diabetes, but they may have early diabetes. So it's a very critical thing to see how that's managed. And what other social issues does she have? I'm an advocate for the social framework of medicine, because if you have a patient with a heart problem who can't get to the hospital because there's no transportation, it doesn't really matter how we treat her, because she's not going to get there. So you've got to really look at those particular issues as well. We've talked about New York Heart classification and the risk factors that we've talked about, so I'll skip those. But I think that the critical things you want to look for are, what are the risk factors for the fetus? The fetus is often an unwitting partner in the pregnancy, and all of the things that we do to the mother have the impact on the fetus, but her own metabolism and her own physiology impacts that. So clearly there's a greater risk, and I'll show you my data on this as well, greater risk for preterm delivery, for IUGR, and for fetal demise. And recently I just found it's also a greater risk for SIDS. I've had 2 patients recently whose babies have died unexpectedly of SIDS. So clearly the worse maternal cardiac function, the greater the risk. LV outlet obstructions are concerns, but age is also a factor. Maternal age under 20 or maternal age over 35 has its own constellation of problems, probably related to the fact that there may be other factors that have led to this pregnancy if you were very young, or if you're over 35, you've had time to build a whole lifetime of other chronic health issues. Maternal tobacco use and everything, treatment with anticoagulants. And I'm looking forward to our talk this afternoon on anticoagulation in pregnancy. In my pre-pregnancy counseling, I'm going to talk about maternal and fetal morbidity and mortality associated with pregnancy. Because one of the things that needs to be done in a more rigorous way is for us to obtain data banks of how these patients do, not so much in pregnancy, I can tell you that, but I want to know how they are 2 months, 6 months, a year out from their pregnancy, and how they are doing, and how their baby is doing. You want to talk about genetic counseling. I'm a geneticist, so I always ask about family history. I want to know their overall life expectancy, hence my question earlier today, because you want to know, pregnancy is 40 weeks, but parenting is lifetime. How many of us have adult children that may still be living at home, okay? So you want them to be having a healthy mother, a healthy parent, and if her health is going to diminish, that needs to be taken into effect. And then clearly you'd want to have a functional cardiac status beforehand, looking at pre-pregnant echo, cardiac consultation, and if she needs exercise testing or if she needs MRI, that can all be potentially done beforehand. The other thing is, talk to them about contraception, and Stacy is going to speak to us later today about that, but I think that it's important for these patients that pregnancy not be an accident. You want them to be optimized when it's the right time for them. As a geneticist, what I want to talk about is what is the nature of the disease that affects both the mother and the father of the pregnancy. If there is a congenital syndrome, the recurrence risk for that in the family is obviously a potential of 50%. And the 2 most significant that I see and that we have the most data on are Holt-Oram syndrome, a TBX5 mutations, or for tetralogy of Fallot with the conotruncal defects with a 22q11 microdeletion. And again, many patients may have only their cardiac function or cardiac abnormalities as a manifestation of this. So it's really critical. Ironically, if it's non-syndromic, maternal and paternal risks are really different. Now, why is this? It's probably some epigenetic in utero effect that alters the environment of the genetic makeup. But if the mother is affected, there is a recurrence risk that will vary from 5 to 11% for the disorder. But if the father is affected, it's only about 4%. So clearly all of these factors are going to be playing into her potential risk. This is really key, I think, in talking about genetic issues, because if the patient is alive and doing well with whatever cardiac disease she has, for her, it doesn't matter that her baby might have that. Or again, it might. She might say, I had a huge issue throughout my childhood. I couldn't do things that I wanted to do. I don't want my child to have to go through that. Or she may say, you know, it doesn't matter. I'm here, I'm fine. If my baby has it, I'll work it through. You can never predict what person descriptions are going to make a change in their own script for their lives and for their child's life. Medications we've basically talked about in terms of this. I'd prefer a single agent if we can, but multiple agents are fine. And as we've mentioned before, I typically try not to use ACE inhibitors. Warfarin, hey, it's going to be as we need it. And particularly amiodarone, we try to avoid as well as our ACE. Our thromboembolism risk, I have to say, this is one of my biggest fears for the arrhythmias, for the mechanical valves, but often because these patients need to be at bed rest for some kind of congenital problem with their chronic heart problems. They may have failure, and that's going to pose an increased risk for them as well. Pregnancy in itself is a huge risk factor for thromboembolism, so again, we're looking at something that's a risk on top of that. And this is the ancient assessment for for thromboembolic risk, and Dr. Ito showed you a more recent one. We'll let our discussion go forth in the afternoon for this. So what do I do with these patients when I see them for their pregnancy? What do I do as evaluation? As I said, this is level C evidence. There's not testing that's been done on each one of these particular things that are done, but I think that they provide benefit and help to me in terms of sorting it out. Obviously, an EKG, and you want to look at their past EKGs and see if there's any changes in what's been going on. I do recommend a maternal echo every trimester. Obviously, my cardiology colleagues are hand in glove in terms of managing this patient, and as I said, exercise testing, cardiac MRI. The labs are a little bit different. I recommend our routine OB labs, comprehensive metabolic panels, and a baseline BNP. I think BNP has been really helpful in getting a sense on whether there's something that's worsening in these patients. The other is that I have found that preeclampsia is extraordinarily unpredictable in this group and does occur in a higher frequency. So I usually start with looking at baseline renal functions as part of your comprehensive metabolic panel. You can either do a 24-hour urine, or you can do a urine PC protein to creatinine ratio as well, but have that as a baseline, because it's going to give you a comparison when the patient downstream starts to look different for you. If we have a patient who is at risk for preterm labor, I will typically give her steroids if I think that her delivery may be between 23 and 36 weeks. Notice that 36 weeks is my upper limit now, no longer 34 weeks. There have been some recent changes in recommendations for that. Or if there's evidence of fetal IUGR and you feel like you might need to deliver sooner rather than later. What do I do for fetal evaluation? Well, the first thing that I do is I verify that the pregnancy is viable, and I do that somewhere around 7 to 8 weeks, because these patients are at increased risk for miscarriage. So you want to make sure that you've got a living pregnancy in there when you actually see this patient. And you may actually have to admit her to the hospital if you're planning to transition from Coumadin to heparin or Lovenox for her therapy. I will do first trimester screening with nuchal translucency and serum analytes if she is a low-risk patient for aneuploidy, or if she's a high-risk patient for aneuploidy, I'll offer cell-free fetal DNA. I do not do the cell-free fetal DNA for 22q microdeletions. The performance of that test, I think, in the cell-free fetal DNA perspective, has been less than useful, with a high number of false positives and a relatively low positive predictive value. So I don't use those microanalytes. I follow these patients every 2 to 3 weeks. Is there any data on how frequently that needs to be done? I tailor it, obviously, to how well they're doing. So if you're doing well, we could try a little bit longer interval. If I think that there's an increased risk, I'll do a shorter interval. They get an anatomy ultrasound at 18 to 20 weeks. I do a fetal echo if it's at 22 to 24 weeks, and serial growth scans on this baby, because clearly one of the risks that the baby has is for poor fetal growth, and this is why I feel like it's a monitor, actually, of maternal function. The fetal growth can predict maternal oxygenation, uterine blood flow, and placental function, and all of those may be affected by maternal cardiovascular factors, angiogenic factors, which impact that fetus. So the fetus is my best monitor in many ways for maternal function. At 36 weeks, I start monitoring the baby for biophysical profiles and non-stress tests, and they may need more frequent monitoring and Doppler studies if there is poor growth. So now what about delivery? I think one of the things that I have found the most valuable in my opportunity to care with these patients is a pre-delivery multidisciplinary meeting, especially if these are really, really complex patients. It includes MFMs, OBs, our residents and fellows, anesthesiology connections, our NICU staff, because they may be called upon to care for a baby in a different setting, our adult congenital heart cardiologist. I always involve my nurses as well, and this is really vital because then they become an advocate for things that you might do a little bit differently on labor and delivery, and will not give you a lot of resistance to that because they've been involved in the decision. The other key piece is that I want the patient there. I want the patient there with her family to say, okay, this is what we're thinking for delivery time. This is what we're planning. What are your thoughts? Where are you with this? What are you going to need to for child care of your other child? Whatever. Involve them. This is their pregnancy, their delivery, and they're very, very eager to have that involvement. Plus, it really, I think, brings a sense to them of who is working with them, and that's super valuable. Any other providers that we might need, nephrology or whatever, I'm fortunate to work at a very large hospital where we have pretty much every adult resource that is needed, and I am grateful to that. We talk about the timing of delivery, the route of delivery, what we're going to do in labor, what are we going to do if there's complications, what is the baby going to have as an issue, and then what is the postpartum management. So what do I do for delivery? I hope for a vaginal delivery with induction at term, not at 37 weeks, not at 36 weeks if I don't have to, but term at 39 to 40 weeks. And the reason for that is there doesn't have to be an induction. They could go into labor on their own, and I've had some patients that do that. But induction at 39 weeks has no difference for fetal outcome and principally normal maternal outcome. So it's reasonable to consider at that time, and it enables you to coordinate and schedule things, which is helpful. There is a lot of data to suggest that the placenta has a hormonal environment that is really important for fetal neural development. And even though we may feel like a 37-week fetus is going to be just fine, if we don't have to deliver early, put it off to 39 weeks. That fetus will do better. I will, however, if the mother is worsening and she is over 34 weeks, I will try to sustain her in terms of her cardiac function, but I'm more likely to move to delivery based on maternal indications at that time. I usually ask for an early epidural, and I'm incredibly grateful to the skills of my anesthesia colleagues, and that's to control pain and reduce tachycardia. I don't want this lady to be stressed or tachycardic in this. She's not going to handle that very well at all. And I'm super cautious with my fluid use. Most of the time in obstetrics, we have like a routine knee-jerk, 125 milliliters per hour of ringers. All of that actually is not calculated, usually based on the expected need for the patient. So I usually start with a lower amount at 100, and that gives me wiggle room to expand if I need to, if I've got changes in urine output. I do monitor her I's and O's very carefully, and this is something I need to engage my nursing staff for. And usually on admission, they'll get all of the routine admission labs, but I'll usually add a BNP and a metabolic panel with magnesium and phosphate as part of that baseline. I have to tell you also, I have never had a pregnant patient who had a normal magnesium level according to my cardiology colleagues. They're all low in their magnesium. So everyone seems to be anxious about this. However, I think that it may be a volume of distribution issue more than anything. You can use cervical ripening agents, misoprostol if needed. You can use oxytocin if needed. And you can use antibiotics in labor if patient is GBS positive or if there's valvular disease. I will use magnesium sulfate for seizure prophylaxis if the patient is preeclamptic. And any of her medications that she's been getting pre-pregnancy, we continue with sips of water during the actual labor process. In labor, she's going to be in left lateral position as much as she can be, And I do almost always ask for IV filters just because of concerns for, as we just talked about, because of air issues and the paradoxical embolism, particularly in Fontans. You want to avoid maternal hypotension, which is why often you may need an ART line. And this is going to be something that anesthesia will work with you in terms of setting up for that. For the patient who's doing very, very well, we can talk back and forth on whether it's necessary, but many times it is needed. I all the time prefer a vaginal delivery over a cesarean. And I'm probably one of the few people in my hospital that does forceps deliveries, so I do most of these shortened second stages with forceps, although other instrument vacuum deliveries are certainly acceptable. You want to decrease the pushing effort of the mother, which can reduce the preload for the patient. But often if you let her labor down so that the head is at about +3 station, it's a very straightforward process to effect that shortened and assisted second stage. What about a cesarean? Who needs a cesarean? I find that the cesarean is usually indicated for, and we'll go to the bottom, standard obstetric indications, but it may be also necessary for patients for whom you think that the actual act of labor is going to be a challenge. So severe aortic or pulmonary outflow obstruction, if there's a dilated aortic root. I had, my last Marfan patient had an aortic root of 5.7 centimeters. And so for her, this was not going to be something where a cesarean, will be done shortly and get you back on schedule. Or if she actually wants another repeat cesarean, of course, we're going to look for that. We usually still want an epidural for that, but they may need more invasive monitoring. And clearly, the management of the blood loss will be vital for hemodynamics. So just in our last few minutes, I'll tell you a little bit about my own personal experience and share where my own levels of concern are. In just about the last 8 years, I've managed 77 maternal cardiac patients with 88 pregnancies. 2 of them had 3 pregnancies and 7 of them had 2 pregnancies. And these are the different disorders that we've seen. I have to add another 2 patients to Marfan syndrome who just came to my office last week. The outcomes are that mean gestational age of delivery is almost 36 weeks, but it does range from 23 to almost 41 weeks, and about a third of these are delivered, a third to half of them are delivered by cesarean. Many of them because of repeat cesareans or of primary cesarean deliveries. Only 7 of those were related to cardiac concerns for cesarean. There were 29 instrument vaginal deliveries, many normal vaginal deliveries, and 2 previable inductions. The complications, interestingly, this is where I say the point. Preeclampsia was, I found in this group, only about 8%, which is about the baseline risk for preeclampsia. But it seemed to be 2 of my patients with a transposition and mustard procedures. So I felt this, as well as those that have a repaired coarctation. That's the knee jerk that you have to remember for your boards, that there is an increased risk for preeclampsia in those patients. The biggest complication were my anticoagulation issues. I had hematomas, intraplacental bleeds that led to IUGR, and so these were challenging. There were patients with diabetes. 13% had preterm labor and pre-RUM, and 24 of them, 31%, ended up with a preterm delivery. Some of these were related to preterm labor and some of them related to maternal cardiac concerns. 14% were IUGR babies, and 7 of those 11, those mothers were on metoprolol. So it is something to advise them that there are medication concerns for that. In the postpartum state, they had no immediate maternal decompensation. One of the ways that I try to manage this is typically after the placenta is out, I will give 10 to 20 milligrams of Lasix IV to really promote fluid mobilization, and it's been very helpful. I've had 2 patients that have had decreased cardiac function, but less than 50% of them go to the CCU, and mostly the time they just like to follow their fluids, and the CCU is totally pissed off and concerned about why they're even there. So it's not necessarily an issue. No maternal demises. Fetal outcomes not so good. I've had fetal demises, stillbirths at 34 weeks, preterm delivery at 23 weeks, and the fetal anomalies are not inconsequential. Pierre-Robin anomaly, Holt-Oram in the affected mothers, one infant with tetralogy of Fallot whose mother also had tetralogy but did not have a 22q microdeletion. So there's other factors going on. IUGR, preterm delivery, bottom line though, 75 out of 79 infants are alive and well. My biggest concern is non-compliance, our stenotic pulmonary conduit, and worsening valvular function. And I will say that if the patient needs surgical intervention during pregnancy, I think she should have it, if that's going to make a difference, especially if she is remote from term. So my conclusion is that we have a very big need for a village, to quote a presidential candidate, in our management of our pregnancies. I think that you need to have a tolerant labor and delivery, and you need to have a high-risk obstetrics group that's not afraid to take risky patients, which is not always a guarantee. My outcomes for mothers seem to be good, but aren't easy. The outcomes for the fetuses, I think we need to do better. So thanks so much. I know I've run over time, and I apologize.
Come sit.